Started. Welcome to EMS Challenge. We're at Brims today. Thanks, Brims, for hosting us, and always thanks to Fire College for setting us up, taking good care of us. This morning we're going to do 12 lead reviews, talk about a few cases, and then have Dr. Payne, wherever he went. Oh, I see you now. Good, yeah. We'll talk about endocrine emergencies. If you're in the Birmingham area, we got lunch coming around noon, and then from 12:30 to 2:30 we're doing a skills lab. We'll be doing surgical airways with pig trachs, advanced airways, have some megacode scenarios, and then pick through CPR. We also have virtual reality people. What's their name, sir? Medcognition. That's a big word. I can't say that. Coming out today as well. So thanks for coming. All right. For those of you that are not familiar, all right, Chief, we already got there we go. With the EMS Challenge, I like that sound. That's good. Like Bewitched just popped up. That's pretty good. Yeah, exactly. EMS Challenge, we started this probably 7 years ago or so to bring more physician-led Con Ed to the region. We've grown over the past couple of years. The Fire College supports us now, but that's the purpose of this. You know, it seemed, 30 years ago when I was doing pre-hospital stuff, there were docs involved. That's kind of tapered off. But luckily that seems to be growing again. UAB currently has 2 EMS Fellows. Those are docs that have done emergency medicine training. They're doing a special training another year in EMS. And we also have our senior residents doing a month in the pre-hospital world with me as well. So we're getting that back to where I think it needs to be. For your certificate, there should be a link in your chat box online. You can click to get your Con Ed. You can also do the QR code if you're in person. If those do not work for you, you can always email alabama@emschallenge@gmail.com and do that by this afternoon, and you get your Con Ed credit for this. All right. Things coming up in the future for the region. We did some regional out-of-hospital cardiac arrest training back in September. We had several agencies represented. The plan is to bring those guys back in January to kind of look at a systematic approach and way we're going to do pick through CPR in the field with the hopes to bring some of the nursing staff, the local hospitals in as well, kind of show them what we're doing. We'll be back at Brims January 19th. Dr. Kurt from UAB Research will be talking then. We're on the road to January 26th. We should have those dates or where we're going to be confirmed, hopefully by the end of this year. In April, the Critical Care Transport Medical Conference is back at Orange Beach. That's a national conference. It's the critical care, the flight guys that meet down there. GEMSCon, that's the EMS Day Conference, joining with FDIC, and that'll be in April. And if you need Con Ed, remember the cycle ends in March. National Registry has waived some of the requirements. You can get all your Con Ed credit by video or teleconferencing. And our YouTube channel is up if you need some of that stuff as well. We also plan to start some podcasts, hopefully by January, that'll give you some shorter tidbits of information so you don't have to spend 2 hours hanging out with me. So thank you for smiling. Good. Updates. The SMEC committee met and at Orange Beach Conference in November. There are some protocols changing coming out. They're going to the Board of Health. And if they are approved, we should know hopefully by January, but things that are coming in the forefront, a couple of big things. One, increased scope of practice in Alabama for the advanced EMT. They'll be able to, if approved, use Epi 1 to 10,000 for cardiac arrest. They can use Versed for status seizures. There's also some non-narcotic pain medications coming to the field, such as Toradol. So a lot of cool things there. The other cool and scary thing is that we're talking about moving all protocols to Category A except for a couple. So there'll be less times you actually have to call med control. We're always there if you need us, but it gives you a little bit more autonomy. The caveat to that is that we are going to require that every agency has a quality improvement plan, an active medical director, and somebody to kind of oversee to make sure this is going well. So get ready, that's coming, right? Cool. Ketamine usage, I haven't seen a lot of issues that in the region lately. That's going well. Remember, ketamine should be height-based or weight-based, right? So it's not the total body weight, but ideal body weight. If you're not sure how to do that, we got some links on YouTube you can look at, or cut the dose in half. All right. Remember, anybody that gets ketamine is a medical patient. They're critical. They're exposed. They get capnography if you have it. If not, they get SAT monitoring. They don't get O2. They get hypoxic. They get airway management. Anybody that gets ketamine goes to a hospital. They don't go to jail. They don't go anywhere else. They cannot refuse. They go to a hospital. Have y'all been following the cases in Colorado? Anybody seen that? Yes, no, nobody cares. Good. A few head shakes, a few birds. Thank y'all. Good. So in Colorado, there was a case that ketamine was used and the patient ended up dying. There's actual criminal charges placed against some of the EMS personnel for that. I don't agree with that, but it's out there. So be advised, if you're using ketamine, once you give ketamine, your patient is a critical patient. They need to be monitored. You expose them, you look for life threats, you monitor them, you manage the airway as needed, and they go to the hospital. Other thing I want to talk about is intubation. So any advanced airway that's used in the field, whether it be an iGel or King or ET tube, if you're doing that, you got to document capnography. And by documentation, I mean you got to put the number down, and you also got to have some way to save that strip, right? That is your objective proof that tube is in the right hole. In the past, it was in our protocols for the state that you had to document that and show proof of that. When we kind of broke up the protocol book to a protocol book into an operation book a couple of years ago, some of that wording went away, but it's still the same. If you intubate somebody, you got to use waveform capnography, you got to document it, and you got to save that. That's your really only legal defense if that tube is misplaced in the hospital. I cannot stress enough, you've got to document capnography, okay? A tube that's placed in the esophagus, all right, if it's not recognized, that patient dies. There's no hope whatsoever. You will not survive that. So you got to confirm that placement. If you're unsure where that tube is, pull it out, put an OPA in, and bag the patient. All right, thanks for almost smiling. Tough crowd. All right, so let's talk about 12 leads. A lot of people talk about 12 leads, I mean, really fancy things. I think for the ER and for EMS folks, this is a screening tool, right? So it's a way we can get objective data, is our patient sick or not sick, things we can manage, right? I know that in paramedic school, we all learned about vectors and things of that nature. And I can tell you, I cannot remember vectors at 2 o'clock in the morning to save my life. I really can't remember about them at 9 o'clock in the morning either, right? So I'll look at 12 leads as a screening tool. And I'll think of it pretty simple. I'll look at the ventricular rate. Is it too fast? Is it too slow? Or is it okay-ish? So if it's too fast, I'm happy with American Hearts. Is it wide or narrow, regular or irregular? Going down that route. For too slow, I look at drugs, electrolytes, and ischemia. Now, I know other things cause bradycardia, but those things you pick up in your primary exam, right? So the 2-year-old that is breathing 2 times a minute and hypoxic looking, right? Blue, cyanotic, and their heart rate is going 70, 60, 40. What's going on with those people? Respiratory, right? Yeah, so you bag them, right? That's easy to pick up. Right, the guy that's shot in the belly, in the back of your rescue, you go into the hospital, heart rate's 140, then it goes 90 and 70, his blood pressure tanks, now he's diaphoretic and not talking to you. What's the cause of his bradycardia? Hypovolemia, right? So you pick that up on primary exam. Things you don't pick up are drugs such as beta blockers, calcium channel blocker overdose, misuse, or maybe an older person who has decreased kidney function and it just builds up in them. Hyperkalemia is a big one. Then obviously heart disease, ischemia, right? So, and then the scary EKGs are the ones that are okay-ish. The ventricular rates between 50 and 140, and you got to look at it and say, okay, is this a heart problem? Is there hyperkalemia? Is there some kind of underlying issue? Those are the scary ones. So too fast, too slow, or okay-ish, right? Here you go. This guy in the corner, he is funny. No matter what you say, go. Other things you got to be able to do is calculate a rate. Yes, I know the monitor tells you the rate, okay, but you should be able to print one out, look at it, and calculate the rate without looking at the top of the paper. I use the box method. So each big box, I start counting from QRS to QRS, 300, 150, 100. I don't care, I don't care, I don't care. Now I keep counting, all right? I know it's way too slow, right? So it's a scale to kind of give you, is it too fast or too slow? You got to know intervals as well. I know that we learned these in medic school. We learned the PR interval talks about first-degree heart block. Is a first-degree heart block scary to anybody? Nobody's going to say anything? I'll say, no, it's not. Who cares, right? First-degree heart blocks, we don't do anything with those. They're not symptomatic. But a long PR can be indicative of hyperkalemia, and that kills people. So it's important we understand that. QRS, okay? If you don't know what a wide QRS looks like, you can't do that fast algorithm and say, is it VTAC or not VTAC? Very important. And then we did some checkoffs the other day at a paramedic school here locally, their final exam, right? And we gave them an EKG that had a long QT, and we stumped about 90% of them, I would say, right? But very important, long QT can lead to a dysrhythmia that kills people. Anybody know what that is? Yeah, prolonged QT leads to torsades, right? So that kills people. Very important we pick that up. So intervals are very important, right? Cool. So this EKG, too fast, too slow, or okay-ish? Okay-ish, yeah, I agree, yeah. So just looking at it, my mind goes to this number and I see 73. I'm trying to fight that feeling though, right? But I start counting boxes and I got 300, 150, 100, don't care, not too slow. So 70-ish is fine, right? So rate's okay. The next thing I'm gonna look for is injury patterns, because injury patterns are important. If we miss STEMIs, people can have a bad outcome, all right? They can die or have a loss of function and can't go back to their regular life, right? So the first place I look is lateral, right? So that's leads 1, AVL, then 5 and 6. And I'm looking for ST elevation, right? And 2 of these leads, any 2, is a STEMI, right? So 1, AVL, 5 and 6. Next place that I look is 2, 3, and AVF. Right? And I use this same pathway every time, because there's some days I've been up way too long, worked too many shifts, and I'm really tired, and I don't want to get comfortable and miss something. So I have this same routine, right? It's brain memory, just like muscle memories out there. So 2, 3, and AVF are my inferior leads. I'm looking for ST elevation. And I look V1 through V4. V1 and 2 are your septal leads, kind of like in the middle of the heart. V3 and 4 are your anterior, kind of middle front part of the heart as well. So elevation there is concerning for a STEMI, all right? And then depression in any of these leads, usually V2 to V4, is concerning for an infarction, a heart attack in the backside of the heart. Okay, so ST depression, that is a STEMI equivalent. I know some of you guys are pretty high tech on EKGs, and the question I get a lot of times is, if I see this, do I do a posterior EKG? And I'm like, I don't, is the answer to that. And the reason is, this is enough information that I'm concerned that this is a STEMI, and I'm going to be, as the ER doc, calling a cardiologist. If they want to do a posterior and kind of work them up more power to you. But I'm calling the cardiologist, say, hey, this guy's having a STEMI, come take care of him. All right. There's no reason in the field to take their shirt off, move the leads around to the back, sit on scene with that, because time is muscle. This is a STEMI. You start your treatment. You move toward definitive care. And the last place we look at is lead AVR. So for years, we talked about lead AVR was only good to see if your leads are on correctly. If you're up in 1 and down in AVR, your leads are on cool. No problem there. In reality, if you're actually up in lead AVR with ST elevation and you got depression anywhere else, it's concerning for a left main disease. So a big left main infarct going on. Sometimes you see it in other folks. If you got the 90-year-old that has got a UTI and they're septic and the blood pressure is low, the heart rate's 120, you'll see this lead here. As the heart rate goes up and blood pressure goes down, this will get elevated, and you get big depression laterally or inferiorly, and that just tells you they have bad heart disease. So we know the heart is strained, okay? So it's not always a STEMI, but if you see it, you put it in the system, and we figure that out at the hospital, right? Because a 90-year-old, are they prone to having heart attacks? Yeah, they can have anything. Sweet. All right, I got 2 smiles. Good. All right. The next thing you want to look at is, after AVR, is then I go and I want to look for my intervals, right? So I'll look at lead 2 for my intervals, all right? So this gives me a great view of the heart. So I'm looking for my PR interval, all right? I'm looking for my QRS and my QT. If my QRS is wide, I move over to lead V1. And this is where I interpret this, right? So I'm looking at my PR interval, my QRS complex to be less than 120 or 3 boxes. Machine says 88. I only see 1 box. I'm content, right? If your interval's good, QT is fine. So QT interval, the way I kind of think about that, the numbers you can use, but I'm from Mississippi and kind of a redneck at times, right? So I'm looking at my intervals, right? So QT should be less than half the R to R. So QRS, my QT should be less than half that distance is what I'm looking for. If my QRS is wide, I go look here, and that tells me left and right bundle branch blocks. And we're going to dig a little bit into that today as well. All right, so the first EKG we're going to look at today. Too fast, too slow, or okay-ish? Okay-ish, thank you. I know, it's pretty good. If you put the ish on anything, it makes it safer, right? Yeah, are they sick? Yeah, ish, I don't know. What's their problem? Yeah, so anyway. So it's okay-ish, right? So rate, they say 170, the machine says 170. I know you're looking at that, everybody does. My hand's on the patient's pulse, I'm checking for regularity, irregularity. I'm also saying, are they diaphoretic? Okay, as I'm doing that, I'm looking at this, and I got 300, 150, 100, so around 100, okay? So very reasonable, all right? So rate's okay-ish. The next thing I'm gonna do is I'm gonna look for injury patterns, right? And I'm gonna look leads 1 in AVL and 5 and 6. So I got deep T-wave inversions, a little bit concerning, but it's not a STEMI. I'm going to look 2, 3 in AVF. I'll look V1 through V4, and I got some ST elevation, V1, V2, V3, right? I go back and look at AVR, not really elevated. It's opposite lead 1, so my leads are on pretty good. Hey, what's up, guys? Thanks for joining. Then I go to lead 2. I'm looking at my PR interval, all right? Maybe a little bit long, QT is a little long, all right? But my QRS is that wide or narrow? Wide, right? So next thing I'm going to do is I'm going to go over here and I'm going to look at V1. And this is going to tell me, am I having a left bundle or right bundle? And you can say, but doc, it tells me up at top, right? Yeah. Don't trust the machine, all right? The manufacturer of the machine says it's about 96% accurate, and I would argue that it's probably not even close to that, okay? So wide QRS, I'm going to V1. If this points down and there's no Q wave in AVL, this is a left bundle, right? So would you call this EKG a STEMI or not a STEMI? Somebody said not a STEMI. Who says STEMI? Who says no STEMI? Who doesn't care? There you go. The guy in the back doesn't care. Roll Tide. I like your shirt. Sweet. So this is a left bundle, right? So this is a left bundle. We'll talk about if it's a STEMI or not in a second. Well, this is a left bundle. So what you see is a wide complex QRS. You got that downward deflection in V1, all right, and no Q in AVL. So a lot of ways to define this. If you look at the cardiology textbook or even some of the Dobbins books I used to read EKGs, I get way too confused with that stuff. So I get a few things I keep in my memory, all right, let me know what's a left bundle, and that catches most of them. So wide QRS in lead 1, QRS points down. There's no Q wave over here, then it is a left bundle, right? Cool. So what causes a left bundle? Anybody know? Anybody care? So we used to say before 2013, if you have a left bundle on EKG and you have chest pain, we thought you were having a heart attack, and we treated you like that. And we realized that that's not the case. You can get a left bundle just from heart disease, right? So ischemia can make the heart get enlarged. It stretches the conduction pathway, so it makes that QRS get wide. But chronic hypertension, chronic drug use, things of that nature can make you have that. And then heart disease itself. Now, if somebody's sitting there with chest pain, diaphoretic, left bundle, I don't have an old one, they could be having a big heart attack. But most folks that are having heart attacks and get a new left bundle, they're pretty unstable. Because if you got enough damage to the heart to make it look like that, you're probably not going to be pumping very well. There's some folks that talk about they use the turn indicator sign to see if it's a left or right bundle. So turning left, pointing down. But I know I live down 280. Nobody has a turn signal in the car anymore. So I don't know if you know what that is. That's funny. Cool. Questions, comments, statements within reason so far? No. So how do you know if somebody's having a heart attack or STEMI with scarbosis, with a 12 lead? It's got a left bundle. Most of the time on your machine, if it shows a left bundle, the machine picks it up, it's not going to read if there's a STEMI or not a STEMI. It quits interpreting, okay? So that's why we as the medics got to look at this and figure out what's going on. So a left bundle, if you see ST elevation that's concordance, ST elevation same direction as the QRS, that's concerning for acute infarct, a new STEMI. They need to be put in the system and managed. If you got concordant depression, V1 through V4, all right, same thing, really V1 through V3, that's concerning. The cool thing is that you can get discord in left bundles that's normal just because the heart's so enlarged. So you got to have greater than one big box of elevation of discord for it to be a new STEMI to be called that. So discord is good for the left bundle. So going back to this one, we've already kind of looked at injury patterns. We talked about it was elevated in V1, 2, and 3, all right? But we also realized that it's a left bundle because the QRS is wide. We went to V1 and we're pointing down. So is this a STEMI or not STEMI by scarbosa? Discord is good. That's less than one big box. So this is a relatively unconcerning EKG. I see a few of y'all are drooling. That's good. Thank you for drooling. All right. All right. However, if this patient is diaphoretic, clutching the chest, they feel like dirt, blood pressure is 90, That's still a concerning EKG. That's when you can still call TCC and put them in the system and say, hey, I got an EKG, this non-diagnostic, but it's a left bundle, and the guy looks like dirt. I want to put him in the system, okay? I've still licensed EKGs like this and sent these folks to the cath lab if the patient fits the build. But if they're just sitting there with chest pain, look fairly well, fairly stable, probably not acute infarct going on. Does that make sense? So left bundles and right bundles are a little bit more complicated, but the things you got to be able to pick up, because the machine, once it reads the left bundle, it's not going to interpret it all. And I'm going to show some EKGs in a second that'll make you uncomfortable. All right, let's look at this one. Too fast, too slow, or okay? Okay, thank you for talking. Praise God, somebody's talking. Yeah, the rate's okay. So box method, 300, 150, 100-ish. So I'm content with that. The next thing I'm gonna do is look at injury patterns. I'm looking 1, AVL in 5 and 6. All right, nothing super concerning there. I'm looking at 2, 3 and AVF. I got some T-wave inversion. So not a STEMI, but it makes me think, is there ischemia going on? Something ain't right. The next thing I'm gonna look at is V1 through V4. And this should make everybody a little bit uncomfortable here, right? About what we talked about a few minutes ago, we called this a STEMI, right? ST depression, here's a posterior infarct, right? So very concerning. I still finish out the things I always do. I go look at AVR. 1 and AVR should be opposite. And now I'm gonna go back and I'm gonna look at my lead 2 for intervals. Pure intervals, okay. QRS is wide. So that tells me I've got to go look at V1 to see is this a right or left bundle. Now the bigger complex QRS is pointing up. So what kind of bundle branch block is this? Right, very good. So this is a right bundle, okay? Like you're turning right in your car with the car turn indicator. So this is a right bundle. And the reassuring thing is, with complete right bundles like this is normal. Okay, so you'll see this on people who are asymptomatic, all right? You'll see it on folks who just have right heart strain from chronic issues. So this is a right bundle, very reassuring. However, if your patient is clutching the chest, the diaphoretic, the hypotensive, they make you uncomfortable, they make you get sweaty and have chest pain, that's still concerning, right? So there's more to the EKG interpretation than just looking at the EKG. You got to look at the patient as well. But this is a right bundle, so I feel fairly comfortable with this patient at this point in the game. Right bundles, things that cause right bundle branch blocks, or anything that jacks up the right side of the heart. Okay, so congestive heart failure. Folks who smoke have pulmonary hypertension. Folks who have lung cancer, it builds up the pressure in the lungs, so that right side of the heart, the right ventricle, has to pump harder, so it gets larger, and you get that wide QRS when it goes through there. PEs. So what's the most common EKG finding somebody having a pulmonary embolus? Anybody know? Anybody care? Anybody want to bet me $3? No, okay. It's tachycardia. The second most common is going to be signs of right heart strain. So right bundle branch block, new AFib, new A-flutter, something that jacks up the right side of the heart. Again, we're not going to talk vectors. I have not had enough coffee to talk vectors at all. But if you get increased pulmonary pressures from a PE, from COPD, all right, lung cancer, something like that, chronic hypertension, chronic left-sided heart failure that causes congestive heart failure, fluid to build up in the lungs, makes this right side of the heart get bigger. As it gets bigger, it takes longer for electrical impulse to travel through the right side of the heart. So you see that wide QRS and a right bundle branch block. Right bundle branch. Still a concerning EKG, just looking at it. But when you think about what's going on, as long as the patient isn't super symptomatic, is reassuring. This is just something I swiped off the interweb, right? Kind of shows you the ischemia patterns. So circumflex is 1 in AVL, 5 and 6. Inferior, or your right coronary, is 2, 3 in AVF. Left main, elevation STEMI. If it's flipped, T-wave is flipped and you're pointing down, then it's a posterior, the back side of the heart. And then lead AVR, both the right main coronary and left main coronary come off at the high right portion, and that's where AVR points. So elevation here is very concerning for a proximal right or left main infarct. So this is something you can stick on your phone, kind of help refresh you when you're working. The only way you get better at 12 leads is you look at lots and lots and lots of them. So if you're working at a place and you run 2 calls a shift and you do 1 EKG a week, you're never going to be able to interpret these things. You're going to have to find some way to look at these. And I get it. When we started paramedicine a long time ago, medics were the gurus of rhythm interpretation, AFib, A-flutter, junctional attack, first-degree heart block, third-degree heart block. We still got to know that. But we also got to be able to recognize STEMIs now, because in 1980, when you had a heart attack, you know what the docs did for you? Yep, you're having a heart attack. High five. All right, don't get up, quit smoking, I'm gonna change your diet, give you some insulin, you're probably diabetic. You sit there for a few days, and if you don't die, we'll let you go home. We can do things different now. We can take somebody having a big freaking heart attack that 15, 10 years ago, they would have either died from or never been able to go back to work or do anything, and we can lyse these people, open up that clot, or put a wire in and do a cath, and they can go back to their normal life 3 days from then. So very important we don't miss these things. The other thing is the machine doesn't do a good job, and I show this a lot of classes. I know you guys online are probably tired of seeing it, but what's wrong with this picture right here? Yeah, how do you get that blood pressure? I'm not sure I remember how to take one that gives me that number. If I had a student tell me that number, I'd look at them like, you need to either drink more coffee or change jobs, right? So the point of that is machines make mistakes just like we make mistakes, right? So use your machine to your benefit, but you should be able to interpret 12 leads too if you're a paramedic, all right? And get ready, advanced EMTs, you're gonna start learning about 12 leads pretty soon too. Welcome to the world of no staffing, right? All right, sweet. All right, so this is a similar EKG to one that was brought to me. I was working down at a hospital near the coast, and the triage tech brought me this EKG. Hey, doc, can you sign this EKG? In the hospitals, we get 10 minutes to look at an EKG once it's done. That way we don't miss STEMIs. If we don't meet that metric of 10 minutes, they take our money away from us, all right? American healthcare at its finest, right? So they hand me this EKG, and that's my expression, right? So EKG, too fast, too slow, or okay? It looks good, very good, right? Yes, yeah. I know where you work. That makes me very uncomfortable. All right, yes, right. Yeah, my first question is, are they alive, right? So what is this? What is this rhythm? VTAC, right? Yeah, that is abnormal. That should make you get sweaty and start moving pretty quick, right? All right, so if you go by the algorithm we talked about, I can say too fast, too slow, or okay. I say it's way too fast. If I start doing my numbers, I'm gonna do 300, 150, yeah, so way too fast, right? Wide or narrow, I got to understand the QRS complex, that is way too wide. And then regular or irregular, I say it looks pretty regular. If I'm with the patient, my hands can be on the pulse anyway to see if they have one, right? And that's how you determine regularity. Don't let the machine trick you up. If you're concerned about is it regular or irregular, touch the patient. So stability is relative to these folks. Do they have a pulse, right? I would bet you all the cash I have that if somebody has that rhythm, if you ask them, do you have any chest pain? What are they going to say? Yes. All right. I would say 90% of the people I ask if they have chest pain anyway say yes. The guy with the chronic knee pain, hey, is your chest hurting? Yeah, it kind of is. Yeah, right. It's just the way we do things, right? But these folks may be in flash pulmonary edema. They may be hypotensive from poor cardiac output. They may be altered because of poor perfusion and just signs of shock, right? So how do you treat this person? What are you going to do? So this guy is altered diaphoretic. He's got a carotid pulse, but no radial pulse. What are you going to do for him after you use profanity? What? Synchronized cardioversion, right? So somebody's throwing pads on that guy pretty quick and going to light him up, right? He is symptomatic, right? What if he has no pulse? What are you going to do after you cuss? Get to Luke, yeah, press hard and fast, right? CPR, right? So start chest compressions. Cool. There's some medications you can use. So amiodarone or lidocaine. In the early 2000s, there were some studies that amiodarone was the better drug for VTAC, VFib, and everybody switched to it. In reality, either one works about the same. State says you can carry one or both. I would say pick one. There's no reason to carry both. They work a little bit different, but the effectiveness is about the same in my opinion. Dose of amio, if they have a pulse, it's 150. You want to give it slow. Anybody ever drawn this stuff up before? What do you see when you draw it up? Anybody know? Bubbles, lots of bubbles, right? There's a fancy medical term for that. Anybody know the medical term? I can't remember the medical term. So Bubbles, yeah, medical bubbles. All right, all right. So just be advised when you draw it up, you will get some bubbles in that. So you may have to backwash and get some saline out of your IV tubing so you don't push bubbles into somebody. All right. But 150 milligrams, lidocaine works pretty good. It's 1.5 mg per kilo. So if you're practicing this in Alabama, it's probably 2 boxes of lidocaine because nobody's little anymore. But routinely we give a box and a half, right? Amp and a half. Cool. So there's amio, there's lidocaine, right? We talked about CPR. If they have no pulse, they get defibrillation. If they have a pulse, they get synchronized cardioversion. In reality, the best thing for these folks is probably synchronized cardioversion over medications anyway. The way I do this in the hospital, if they're altered and confused, I think they're self-sedated. So I hit the sync button, I charge, and I fire it off, and they cuss me one time. If they're awake and alert, have a decent blood pressure, and sometimes you'll see that, those people I'll sedate with a little bit of medicine, a little bit of Versed, maybe some etomidate. In the field, if you had to do this, maybe even a low-dose ketamine or something, and obviously that's going to be Cat B, and this you're doing advanced practice stuff. But if they're awake and alert and not super symptomatic, I'm still going to synchronize cardio over them pretty quick, but I will sedate them. All right. This is a guy that we had cardioverted, and we had the 12 lead still on him and running it, and he went back into his little issue. All right. This one, too fast, too slow, or okay. This one's kind of tricky. It's kind of fast, yeah. My definition of fast is 140 or greater. So if I was doing my normal definition, I'd say, well, it's not too fast, but what does that look like to you guys? Looks like the last thing we just looked at, right? So when first looked, it makes me think VTAC. Makes me uncomfortable, right? All right. So when you see a Y complex tachy rates less than 140, it should make you concerned. Is it really VTAC, or is it an AFib with a jacked up QRS at baseline? Is it hyperkalemia, something like that? All right. So a lot of red flags. All right. So if this was a 20-year-old, I think they probably are not prone to going into VTAC. I'm gonna think there's something else going on, an electrolyte problem, something weird. Maybe they have a congenital heart problem. You can ask that question. If they have a big dialysis graft on the arm and you're picking them up at DaVita, what's going on with them? Hyper K, right? So use the surrounding, all right? If they're not sweaty, not diaphoretic, it's probably not VTAC, all right? And last weekend, oh, y'all can't see it, can you? Because of there. Put it too low. Last weekend, you saw a lot of that. It says an Auburn fan. That's kind of inappropriate humor. Yeah, right. So yeah, so usually this makes me uncomfortable seeing these VTACs or slow VTACs. There's really not a slow VTAC. However, this patient, they were mature, they were over 50, right? And they had an underlying history of heart disease, a couple of heart stents, on a lot of medications for irregular heartbeats. So that makes me think they're at higher risk for having VTAC. The medic called, got orders, and actually did synchronized cardioversion, and we got lucky. It was VTAC, and you can kind of see they got the sync up, one shock at 100 joules. The medic's mama got called a dirty name. And then we get this back. Very bradycardic. Cool, that's the next point. So this rate is way too freaking slow now, right? If I do 300, 150, 100, 70, 60, I forgot. My hand's on their pulse. Do they have a pulse? I'm cycling the blood pressure. I'm opening my fluids up, right? So when you give somebody amio or lidocaine and they're in VFib or VTAC, alive or dead, and you cardiovert or defibrillate them, and you get a rhythm back. Remember, you just gave them a freaking drug that suppresses ventricular output, right? So now you may shock them out of this, but you've already depressed the heart some, so they may come back super bradycardic, right? So my advice, these folks that are bradycardic post-arrest, there's one drug that's still really great for that, and I talk about it a lot. It comes in a red bag. It's something that people used to buy on the street a lot. Dope, I mean, yeah, okay, I thought it was funny. So dopamine works pretty good. So amio, you give amio to somebody, and then you synchronize cardiovert or defibrillate them, and they come out of it, and they're bradycardic, hang the dopamine. Dopamine increases heart rate and blood pressure. it fixes it all the time. And that's the one time cardiology actually likes a drug and they'll high-five you. I know what they're saying when they high-five me, but they high-five me. I think then you're hosed. You got to do push-dose epi. You got to do something, right?
So it does give some effect.
Yeah. So yeah, I mean, epi is going to increase the heart rate, but yeah. I probably normally when I'm talking about bradycardia, I go atropine first. I got this algorithm I use. This I know what the cause of it was. They had a big ventricular problem. I shocked them. I gave them medicine, so I caused the bradycardia, which is still better than the VTAC. So dopamine's better. If you don't have it, you got to do something. So open the fluids up, give them a second. If they get better, great. If not, they'll be doing the push dose epi or epi infusion if you don't have dopamine. I would not do atropine. I would not give calcium because I don't think there's hyperkalemia because we fixed it with the, right? So if this was hyperkalemia and I did this, what are you going to see? Death, right? So they're going to go into VFib, all right, or asystole if you cardiovert hyperkalemia. Does not turn out well. Yeah, kind of not funny. Good question. I like it. My next slide. This is my clean humor for the day. Pretty good. That's right. All right. Too fast, too slow, or okay? It's okay. Yeah, it's not, 140, 150. You start thinking it's a heart problem. So it's a little bit fast. Machine says 114. I got 300, 150, 100. So between 100 and 150, I'm good with that. I look injury patterns, 1 AVL, 5 and 6. Makes me a little uncomfortable. It's not a STEMI, but it's some T-wave inversions. I do 2, 3 and AVF. Same thing. I look V1 through V4. Very concerning for a posterior infarct. I go here to AVR. I'm a little bit up too, right? So I'm a little bit more uncomfortable. I look AVR and 1 are separate. I go to lead 2. Don't really see much of a PR. Machine sees something. I don't see much. QRS is wide, so I go over here. It's kind of half and half, right? So is it a right bundle or a left bundle? Yeah, I'm going to say it's still kind of be kind of right? I got a wide QRS, right? I'm going up. That's the wider portion of that. So if this is a right bundle, this is okay. If the patient is concerning with the symptoms, the history, I'm still going to treat them like an acute MI. I'm going to call TCC, put in the system, because this is just going to say incomplete or complete right bundle branch block and stop interpretation. And I move on down the road. What about this one? Oh, man. You already got my cheat sheet. I didn't put the other one. Garbage. Yeah, so my first question is, excuse me, sir, are you alive? Kind of poke them a little bit. I would say this rate's way too slow, so 300, 150, 170, I'm getting concerned. I also have this Y complex, rhythm. I look injury patterns, 2, 3 and AVF, V1 through V4, that is wide freaking QRS. AVR, don't really even see anything. So if this was heart block, bradycardia from a cardiac origin, this patient is going to be hypotensive, ill appearing. This is actually looking at hyperkalemia here. So if they're too slow, I think of 3 things: drugs, electrolyte, or ischemia. So this makes me think hyperkalemia. So how would you treat this patient if you thought hyperkalemia? They got a big dialysis graph. They missed dialysis. They had to go smoke some crack. Calcium. So calcium gluconate, calcium chloride, whatever you got. Stabilizes the membrane. All right. The 3 S's. There's stabilization, shift, and excrete. So calcium stabilizes that cardiac membrane. Relatively safe drug to give for these folks. In the hospital, we give insulin and D50, and that shifts that potassium from outside in the vascular bed back into the cell. Pre-hospital, most folks don't carry this, but you do carry albuterol. Albuterol is a great drug for hyperkalemia. You want to do about 20 milligrams, so 4 nev treatments, all in one nebulizer, put it on the face, and crank it up, right? It'll increase the heart rate, right? And it also shifts that potassium back in the cell. You'll actually see the EKG change. When that nev treatment wears out, though, it goes right back. So if you got a long transport, keep hitting them with albuterol, right? Those are the shifts. Excretion in the hospital, we can put a big IV in them and do dialysis, all right? And then the one that the nurses really like is we can give medicine that makes you poop, and you poop out the potassium. Nobody else likes it. I like ordering it right before they go to the ICU, so somebody else gets it. So for you medics that like to do a lot of advanced practice, do not ask for this medicine in your rescue because you don't want that to happen to you. I just like that video, sorry. Cool. And this is the EKG, the same person. This is after they got some albuterol and a little bit of calcium before we finish treating up. But you can see that the QRS is getting much better. It actually looks more like a freaking rhythm now, not PEA. Too fast, too slow, or okay? Yeah, it's okay. All right. I'm looking at injury patterns 1, AVL, 5 and 6. Nothing super scary. 2, 3, and AVF. I'll do V1 through V4. I got T-wave inversions. There's no ST depression, but that is a weird looking morphology, isn't it? Yeah, that should make you uncomfortable. All right. Not a STEMI, but makes you uncomfortable. I'll look at AVR. Looks fine. AVR 1, okay. Look at my intervals. My intervals are reasonable, so I didn't have to go over here. All right. Before I put this EKG down, I'll look one more time at injury patterns test because that makes me uncomfortable. Anybody know what this is? What this syndrome is called? So this is called Wellens, and this is somebody that has stenosis or a big plaque going down the left main, and you'll see this deep T-wave inversions and this funky little rhythm here. All right. And they have this at rest normally. If they start having ischemia and this starts hurting, a lot of times these T-waves flip up and they have a normal looking EKG. So it's very important for us in the hospital, if somebody comes in with chest pain and we start working them up, when their pain goes away, we repeat that EKG to make sure this doesn't flip back down. Because this is very concerning for somebody that's going to eventually have a STEMI in the near future. But it's called Wellens. You can Google that. That's the classic Wellens. These people, we do not send them for a stress test if they have heart disease, because when we stress them, they have STEMIs, and they go from the stress test to the cath lab. So these guys, even if their blood tests look good, they get admitted to cardiology, and they get a heart cath to look and see what's going on. You can have this EKG finding and not have heart disease, but it's fairly common to have this EKG finding and have heart disease, and it's better to pick it up and not die than not pick it up and die. That was kind of funny. Too fast, too slow, or okay? Okay. 1, AVL, 5 and 6. Looks abnormal, but not a STEMI. 2, 3, and AVF. I'd say that 3 makes me uncomfortable, but that's just one lead, so not a STEMI. V1 through V4, I'm elevated in 2 and 3, a little bit in 1, a little bit in 4. Makes me uncomfortable, right? I look at AVR. AVR is wide, but it's opposite 1. So I go to lead 2 to look at my intervals. PR intervals a little bit long, maybe. QRS is wide. So I'm going to go to V1. It points down. So I agree with the machine. This is a left bundle. So I use this test. What was the test we used? Y'all remember what it was called? Scarbosa. Isn't that dude's name from that cartoon, Scarbosa? Was that his name? Oh, crap. It's close. So Scarbosa, right? So Scarbosa is discord is good as long as it's less than 5 millimeters, right? One big box. So discord is good. So this does not meet STEMI criteria by Scarbosa. What about this one? Y'all can determine if the rate's too fast or too slow. Y'all look at injury patterns, 1, AVL, 5 and 6, 2, 3, and AVF, V1 through V4, AVR. Go back and look at your intervals. Look at your QRS. Go to V1. Is it a left or right bundle? So what do you think? Machine says it's an abnormal EKG, left bundle branch block. What do y'all say it is? You can't say it's an abnormal EKG with a left bundle branch block. That's like cheating. The thing that matters for us and somebody that's symptomatic is it STEMI or no STEMI, right? Somebody needs to commit. Who here is married? All right, commit. STEMI or no STEMI? STEMI, I concur. Yeah, that's a medical term, concur, right? Yeah, right. So injury patterns. 1, AVL, 5 and 6. That makes me get sweaty, right? I'm starting somebody, hey, he needs an IV again, a second IV right now. You go get the pads, all right? Bring out the O2 tank, all right? And then I come back, 2, 3, and AVF. Make me very uncomfortable, right? So now I'm sweaty. V1 through V4. AVR looks okay, all right? We kind of talked about intervals here, wide QRS, so I know it's going to V1, left bundle. So now I use Scarbosa, right? And with scarbosa, concordance is bad, right? So this is concordant. QRS, same direction is the T wave. So that there is enough to say it's a STEMI. If I was looking at just inferiorly, it's not a STEMI. This is discord. QRS one direction and the T wave the other direction. Discord. Discord is good, right? Like marriage. Discord is good, right? And it's not more than one big box. So this doesn't concern me now. I got that bundle. This is a freaking STEMI. That does not say it. If this guy gets to a hospital and sits on the wall for 20 minutes for the nurse to get vital signs, I'm not dinging nurses, nobody throw things at me. The world's crazy, all right? Then waits 45 minutes for a room and you don't recognize this guy has a bad outcome. He's got a left bundle, which means he has either a already bad heart at baseline or this STEMI is causing a bad heart and he's having a STEMI. So you got to be able to pick this up. All right, the days of medics not reading 12 leads are over. Scarbosa. Sweet. This one's a little tricky. That's for the physicians in the back. Y'all should know what that is. All right. So I would say looking at injury patterns, rates okay. I start looking at V1 through V4. Yeah, makes me uncomfortable, but I've seen a bunch of left bundles, so I don't really care. Call it a day, right? But if you go look at lead 2, I look at my intervals, PR is fine, my QRS, right? So QRS is like that, so I'll go here. Left bundle, not a STEMI, right? But what's the problem? Is that QRS wide or narrow? It's narrow, so I can't go there. There is no left bundle, right? So people will miss these sometimes if the machine misses them because you're thinking it's a left bundle, right? It's not a left bundle. This is a big freaking septal anterior STEMI. Dude's going to lose most of his heart if we don't pick it up and get him to the cath lab now. Perfect. That's trichomonas. Tricky. All right. This is a paced rhythm. The machine will also tell you ventricular pacer cannot interpret. So it won't pick up things. But this is a paced rhythm with a funky QRS. Anybody know what this is? I'll give you a hint. They got a dialysis graft. Hyperkalemia, yeah. So you can use scarbosis on paced rhythms to look for STEMIs. You can also realize that you get hyperkalemia with on paced rhythms, and you can actually see it. Oh, that's a cool, funny thing there. That's right. Chief Ward likes Chuck Norris, don't you? Yeah, okay. My God. So this is a 60-year-old male, some nausea, a little bit of weak. He vomited once. Obviously, what do? Y'all got it made. This is an EKG class today, so you know we can get an EKG, right? But remember, we get 12 leads on people with ACS equivalents. So that's nausea, vomiting, diaphoresis, shortness of breath. I done passed out. If you're over 60 and you don't feel good, you get an EKG, right? There's no harm to getting an EKG. You're not going to give them radiation poison. You're not going to do anything harmful to them. All right. The only harm for doing an EKG is you got to look at it and interpret it and do something with it. All right. Semi-inappropriate humor. And this is that guy's EKG. What do you think? Good, bad, indifferent? Anybody even care? Good. Right bundle. Somebody can read from the back. I like that. Very good. All right. Machine says nothing. So what are we going to do for this guy? All right. We kind of looked at it. Y'all made y'all's decision. You don't have to share it with me now. All right. So chest pain, concern for ACS, right? We got the Mona or Fona, right? So he's going to get aspirin, right? So you get an aspirin. Aspirin is going to jack up the platelets. So if he's having a heart attack, right, it's going to make the blood flow not less. So when you have a big clot and you're having a STEMI or ACS, aspirin stops the platelets from binding, so this clot does not get bigger. It doesn't make the clot go away. It makes it not get bigger, okay? What is the N in Mona? Anybody remember that? Nitro. What does nitro do? dilates the vessels, right? So it makes this bigger so you get more blood supply. Remember, if you're giving somebody nitro for chest pain, you need an IV access before you do that, right? Because what happens if you give them too much nitro? Drops the blood pressure and you can kill somebody. Not good, right? Right? The other O is oxygen. I know American Heart says we don't do oxygen if their SATs are not less than like 95%. I agree with that, and I think there's a STEMI. I think there's a STEMI. They're going to get pre-oxygenation, so they get nasal cannula at a couple liters. That way, if they start dying on you, you can crank it up and do passive O2. And the M is for morphine. So morphine also increases this space, dilates these vessels. You get better blood flow. And if you give them morphine, they kind of like you a little bit more too. They go from I'm having chest pain and dying to like, hey, I'm having chest pain and dying. Can you put the Eagles 8-track on, right? FONA is changing morphine for fentanyl. There's really not much benefit for that unless they're already hypotensive. But if they're hypotensive with chest pain, I'm probably not giving them a narcotic anyway. I'm too busy managing their hypotension with fluids, medications, and moving down the road. But you can use fentanyl. Some people talked about CONA with ketamine. There is no indication for ketamine in concerns for ACS. Ketamine will increase your heart rate, increase your blood pressure, and actually make the heart do worse. So ketamine is not there. If somebody's having a big STEMI, things that we can do in the hospital is we can give them a clot buster, right, and dissolve this clot and restore flow. Or we can go in with a wire and put a wire in, balloon this up, and put a stent and increase the blood supply. Obviously, they got to be anticoagulated for that for a couple of days. So that's the way we kind of manage that. STEMIs are high risk. Things that kill you if you're having a STEMI in the first couple hours are VTAC or VFib, or complete heart block and cardiogenic shock. So these guys get pads put on them if you think they're having a STEMI. High risk. Big STEMI. This crew did a great job. Aspirin, they put pads on the patient, went into VTAC. So they just put their cigarette out, charged to 200, and shocked him. And the guy came into the ER calling us all names, but he was alive. Then he got sedated and went to the cath lab. Right? Cool. So let's go back and look at this EKG. STEMI or no STEMI? Who says STEMI? Raise a extremity. Okay. Who says no STEMI? Raise an extremity. And then, like most Americans, nobody voted, and that gets us into trouble, people. Just saying. So yeah. So we got rates okay. 1 AVL and lateral looks reasonable. 2, 3 in AVF. Nah. T-wave inversion okay. V1 through V4. I got some elevation there, right? I go back, I look at AVL, it's not really opposite 1, but it's something weird, right? Not good. I look at lead 2, P interval's good. QRS is a little bit wide, right? Greater than 120. So I go to V1, is it a right or left bundle? It's pointing up, right? So it's a right bundle. So with the right bundle, what should this look like? It should be depressed. It's not. Now it's up, right? So this is a big freaking STEMI, and the machine doesn't pick it up. So we got to be able to look at these things and pick it up. So this is a big STEMI. You miss this, you can have a bad outcome. All right? Crew did a good job recognizing this one. Now. So cath reports, you got, we put the wire in. We don't, the cardiologist does. They put the wire in, they squirt some dye. You can look at it. You can see there's limited flow. They put a stent in, increases blood supply. This is an Impella. This is something you stick into the heart, and it kind of helps blood supply come out of the heart and push it back in so that the heart gets a better blood supply. That's the redneck interpretation of it. So big STEMI. Crew did a great job recognizing that. Too fast, too slow are okay. I would argue the rate's okay. If you look for your injury patterns, I know you hate me saying it again, same way. Put it to memorization, 1 ABL, 5 and 6, 2, 3 in AVF, V1 through V4, looking at AVR. I go to my intervals. Before I put it down, I look one more time. And this is, so this one looks reasonable, not a STEMI. So the EKG is unremarkable. Patient did not look well. And this is the EKG about 15 minutes later. What do you think about that one? Yeah, now I didn't look well, right? So too slow, I think 3 things: drugs, electrolytes, or ischemia. He's been in front of me for 30 minutes, so it's probably not drugs, probably not electrolytes. So this is ischemia. This is a big freaking heart attack. Complete heart block, bradycardic, right? So remember, EKG just gives you one point in time. It's like one set of vital signs. If you check the vital signs when you're a gunshot victim, and they're great, and you don't check them again for 45 minutes, and you get to the hospital and he's dead, you miss something. Same thing with 12 leads. Get them. If they make you uncomfortable, repeat it every couple of minutes. It's not going to hurt them. It may pick up something pretty important, right? This is just a right bundle I saw in the ER the other day. I thought it was cute. The doctor circled the T waves. I'm like, yes, those are normal. You're correct. And this is that one we kind of talked about a few minutes ago. Very important to pick these things up. Machine is not going to pick this up. So you guys got to recognize this. If you don't recognize it, you recognize the patient is sick, keep hitting repeat 12 leads. At some point, as this gets really abnormal, the machine would say concern for ST. But you got to be able to interpret 12 leads if you're a paramedic. Okay. So Trustful did this one. It was a great save. Anybody know what this humor is? Nobody gets my humor. It's kicking butt and taking names. Get it? Ferris Bueller taking names. And I thought it was funny when I did that. So, all right. Sweet. All right. Maybe not. So, remember, the only way you get better at anything is to repeat it. For you folks that are healthy in here, all right, you stay healthy by eating well and exercises, just like I do, right, every day. Same thing in medicine, man. If you don't read 12 leads, you're not going to get better. If you don't do a lot of IVs, you won't be a good IV sticker, right? If you don't review your drugs and know how to do pit crew CPR, when it's time to do it, you can't do it. You got to train, all right? Or you're going to feel bad about it. I'm trying to think about, oh, yeah, so this is pretty cool. Have y'all seen these toys at Five Below? These are pretty cool. Anybody seen them? Yeah. So I put these up here. I got 3 rules that I try to keep going. Is one, I don't want to kill people. The things we do in healthcare, we carry medications and things that can hurt someone. And we also have a responsibility to pick up things and use those medications. If we don't train and do it well, we kill people, right? I try to do what I can to help people. Some things I can't fix. If I recognize somebody has a brain bleed, I cannot take off their skull and fix that. If I take your skull off, you're going to die, okay? But I recognize it and I get them to the appropriate place. I get them to a neurosurgeon. You can't fix their STEMI, but you can recognize it, start the treatment, and get them to an appropriate place as well, all right? And I go home with a clear conscience, and I do that by training every day, all right? If I can't train physically, and I'm training mentally, I'm thinking about cases, I'm looking at 12 leads, I'm reviewing cases. The work you do in healthcare is important. People will die if you don't do a good job. I know it's corny, but it's the truth. I like these slides because if you look, this is the doctor, this is the EMT. You notice the doctor has bigger arms, right? All right? And we also carry a stethoscope different, right? So it's like, rock on, right? Perfect. And then I got this slide up here because if you think, calling, I think that EMS medics should move more toward a provider status where you understand your scope of practice, you assess patients, and you manage them, just like a nurse practitioner or a physician, right? But calling you guys a provider is like calling this guy a day laborer, right? There's a lot more to it. There's scene safety. There's the ever threat of being recorded. There's violence. There's city management, state management looking at you. So in short, I appreciate what you do. But in short, you got to train or people die. We have 1 minute, so we'll take a break, 5 or 6 minutes, and we'll come back with Dr. Payne. Thanks for smiling.
Before we wrap up, so we did have a little sidebar discussion on text. So
Okay.
For left bundle branch, we've got Scarbosa criteria to help us determine whether it's a STEMI or not.
Yes, sir.
Is there a set of rules for right bundle branch?
To my knowledge, no. So right bundles, you're going to see a complete right bundle. You're going to see that T-wave inversion, ST depression, V1 through V4, and that should make you feel good if it's a right bundle when you see that. But if the patient is symptomatic, you still should be concerned about them.
So is it fair to say if you see ST elevation in those leads, like you did in one of your examples, then you should lean towards STEMI?
You should lean towards STEMI, right. So if you see a right bundle and it looks normal through V1 through V4, you should be thinking STEMI if they're symptomatic. If you see elevation, you should be already on the phone telling somebody as you head to the hospital to a cath lab.
Gotcha. Thank you.
All right.
All right, everybody online, always, we want to thank the Alabama Fire College for sponsoring EMS Challenge, and we're ready for Dr. Payne. Take it away, sir.
All right, let me make sure this is on. All right, guys, so we're going to be talking about endocrine emergencies today. I know we're starting a little late, so we'll try to get done at 12 so we can get lunch for everybody. So let's first start off with a case. So you're called out to a 27-year-old male. He's altered, not acting right, he's combative. You pull up on scene, he's running around in the yard, may or may not have clothes on, looking for his lost keys. You arrive on scene, you see the police kind of running through the yard chasing after him. So what are your thoughts? Kind of just general thoughts, not knowing this is an endocrine lecture. Yeah, scene safety, right? What do you think might be going on with this guy? I mean, you know, altered mental status, so there's a huge range of things, right? But most likely, a lot of people are going to be thinking this, right? Drugs, because 10 times out of 10, that's what it is, unfortunately, right? By the way, this is the generic photo for drugs. If you Google drugs, it's just, wonderfully set out there. So you kind of get there, you get things figured out. The police finally wrangle him down. His mother's there. Said, he's never acted this way before. He doesn't use any recreational drugs. Does that change what you're thinking? No, right? Right. Everybody lies, right? But you still, you talk some more and you feel like, oh, he's been diagnosed with diabetes recently. He started on a new medication. His mom's like, I don't really know what it is. It's something he injects, right? Does that change maybe? Yeah, right. So this is another case, and we'll come back to all these at the very end. 53-year-old male, palpitations, altered mental status. You get there, he looks like crap. He's lethargic. He's not really knowing where he is. He's tachycardic to 150s and sinus tachycardia. You kind of start asking some questions to family members. They're like, oh, yeah, he had some heart history. He's been started on a new drug called amiodarone a couple weeks ago. But other than that, no new meds, okay? So what about this one? Again, not necessarily thinking this is an endocrine emergency class. So you may think sepsis, right? Tachycardic, altered, if his blood pressure's low, right? Maybe electrolyte issue. Is this VTAC again? Does he have a history of VTAC? That's why he's put on amio, right? Or it could be endocrine emergency. Talk about it. And then the last case, 75-year-old female, general illness. When you get there, she's pale, say she's been feeling bad for the last 3 days. You hook her up to the monitor. She's tachycardic, hypotensive, normal sinus rhythm on an EKG. She has a history of lupus. She takes steroids every day. She's done that for the last 10 years. Is the only medical history you get out of her. Otherwise, no cardiac issues. So any thoughts here? Any takers? Again, it could be, common things being common. You think sepsis maybe. You think ACS, even though it's showing normal sinus rhythm. Or could it be an endocrine emergency? Maybe so. We'll talk about it. All right, so the three big ones we're going to talk about today are, of course, diabetic emergencies. That's going to be greater than 95% of everything you see in EMS. Some adrenal emergencies at the end, and then thyroid storm or hyperthyroidism as well. So again, you think about endocrine, it's just all the different glands in your body that produces hormones. You got your pineal and pituitary gland in the posterior inferior portion of the brain that kind of regulates all the other glands. And then the big hitters are adrenal, pancreas, and then your gonads, which control your sexual hormones that we're not going to talk about today. So let's talk about diabetes, right? Most common endocrine disorder. There's about annually 25 million people with this disease. It occurs more frequently African Americans, Hispanics, Native Americans, and usually there's about 1.5 million new cases diagnosed each year, so very common. There's a ton of ED visits related to this, with the two most common emergencies being hypoglycemia and DKA, right? Those are the big ones we care about. So we'll talk a little about each type of diabetes, kind of the different things you want to think about with each one, different questions you want to ask, okay? So this is the pancreas on the left. You have all these cool, weird, different cells inside that produce different hormones, right? So the one we care about right now is this beta cell, okay? That's the one that's going to secrete insulin. So in type 1 diabetics, those beta cells get blocked out for different reasons. Maybe it's a viral infection, autoimmune disorder, and your beta cells just can't produce insulin anymore, okay? This usually occurs younger. Adolescence is usually when you first get diagnosed with this. And these people are insulin dependent, right? They make no insulin on their own, so they have to get insulin to survive. Okay. Again, diabetes, there is no cure. All the things we're doing is just supplement the hormone and try to treat the symptoms. So type 2 diabetes is much more common. This is going to be 90% of all the diabetics you see out in the field. Rather than an insulin production issue, it's more of the body is resistant to the insulin itself, okay? This is related to people that are obese, smoking, other genetic factors can play in, but usually it's those major risk factors. And what happens is with obesity, you have increased insulin levels all the time at baseline because all the sugar intake. Well, when your body sees all that insulin all the time, it deregulates your receptors, right? So it just becomes more resistant to insulin. And that's why these patients just have to get more and more and more insulin, right? They're not insulin dependent, meaning that the body does produce a certain amount of insulin, but it's not enough, or the body has become insensitive to it. So there's a lot of different diabetic medications. The most common you'll see in type 2 diabetics is metformin, right? That's your first go-to medication. You'll see almost everybody with diabetes put on this. You'll see some sulfonylureas, which is another oral medication as well. We'll talk about those and why those are important when we talk about hypoglycemia. And then if all those fail or you're a type 1 diabetic, then people have to be put on insulin, right? So the standard regimen is what's called a basal bolus. So you get like a daily injection that gives your long-acting insulin that just kind of gives you a low rate over time, the whole 24 hours. And then you have boluses that you give yourself when you eat, okay, for those quick spikes in blood glucose. And you can see how this is very tedious. Even people with moderate compliance, you can see how this can be messed up. You can see where people will just not, care about it that much. If you give this, injections 4 times a day, that means you're going to be at least checking your blood sugar 4 or 5 times a day as well to make sure you're doing this properly. So there's a lot of area for non-compliance, even in people that usually can take medicines fairly well. We'll talk about insulin pumps real quick because they're becoming more common that you'll see, right? So this is basically doing the same thing that the person is that would be injecting insulin, right? So it's this little thing they wear. It's got a little tube that runs through a little subcutaneous tissue, usually in the abdomen. And just like you give yourself injections, it has a basal rate and a bolus, okay? So it constantly gives a basal rate of short-acting insulin. And then when you eat a meal, you can hit a button, and it will give a bolus of insulin over time, okay? So it works a lot easier than having to give yourself injections. Usually these are coupled with this CGM, continuous glucose monitor, which is another little sensor that continuously monitors the blood glucose. So in real time, it can give feedback of, hey, this is your blood sugar. You might want to do another little bolus, things like that. A lot of times these will have alarms if the blood sugar gets above or below a certain level. So you'll hear audible beeping with these as well. So everything speaking of diabetic emergencies, everything that I looked up, all the recommendations are really, even in a hypoglycemic patient, to just treat them as if they are a normal diabetic, okay? You don't necessarily have to pause these, stop these, clamp these, worry about removing them. Just treat them. Otherwise, give them some sugar and send them to the hospital and figure out what other reason that they might be hypoglycemic, okay? And the reasoning behind that is these patients are usually type 1 diabetics, and they can go into DKA fairly quick if you just clamp it or completely discontinue it, from the stuff I looked at. All right, so the biggest emergencies, right? Hypoglycemia and DKA. Hypoglycemia is actually by far the most common emergency you'll see in EMS. So key elements, just like everything else, right? Your ABCs and level of consciousness is what you're going to assess when you get on scene. Airway, breathing, circulation. When these patients become hypoglycemic, they can lose their protective airway responses fairly quickly. How responsive are they? And then you're going to check vitals and a glucose. Things you want to think about are what meds they're on, okay? And then also, if you can kind of start getting an idea of why they may be hypoglycemic, right? Have you been eating normally? Do you have a GI bug? And you haven't been eating, but you've still been taking your insulin, any recent medication changes, right? And then the most important one for this when you're thinking about meds is those sulfonylureas that I talked about, which is an oral hypoglycemic or oral diabetic medication. And it will cause prolonged hypoglycemia. Even if they take the right prescribed amount, it's just a known complication. So if these patients come into the ER and they're hypoglycemic and they're on a sulfonylurea, we usually have to either admit them or watch them for an extended period of time because they have a chance of rebound, okay? So it's just something to think about and good to ask. All right, so you're called out to a 27-year-old male, history of diabetes, type 1, ultramental. He's stuporous, but he is protecting his airway. He's only minimally responsive to pain, glucose 35, otherwise his vitals are good, right? So what's your next steps? What are you thinking about, right? So you're going to be thinking about giving them sugar, right? We'll talk about the different ways and different protocols as well. So most common diabetic emergency is hypoglycemia, and why this happens so often is there is a very tight window that physicians will try to keep your blood sugar level because that will greatly decrease all the badness that happens with diabetes. So your retinopathy, your MIs, your strokes, right? The more they can keep that glucose over time in a very tight window, the more your risk of those complications go down, okay? But of course, with that comes overdosing and hypoglycemic episodes. All right, so usually it's defined as 70. Sometimes you'll see 60, less than 60 or less than 70. It's actually pretty common for this to happen. Diabetics will suffer mild hypoglycemic episodes 1 to 2 times per week. Usually it's self-treated. They'll check and they're like, ooh, it's 40 or 50, and then they can eat something real quick and it'll correct on its own. Okay, so very common. So treatment, right? Sugar. We got to give them sugar back. Okay, basically your options are oral glucose, IV dextrose, or IM glucagon, okay? So oral glucose, it's great, but the one caveat is it's got to be in people that are protecting their airway and awake, right? You don't want people aspirating this stuff. So what used to be the big thing was D50, right? Everybody packed D50 would carry this. And then with the drug shortage over the last 4 or 5 years, a lot of people are going to D10. Usually 1 amp will raise your glucose levels about 150 on average based on previous studies. It has very rapid onset. I'm sure y'all have all seen this in the field. The big complication with this one is it's very hyperosmolar. So if there is some extravasation or a blown IV when you're giving this medication, it can cause local tissue damage. Okay, so it's always important that if you're giving this, to give it slow and to give it in a good working IV. And then this is the new thing everybody's kind of gone to is D10. As less of the side effects of the tissue damage if it extravasates in that local area. There's been a lot of studies that show that if you just infuse this versus giving that bolus of D50, the time that the patient regains consciousness is about the same, okay? So it really has the same efficacy as pushing D50. And then there's also some idea that there's less of an overshoot, right? So if you give a big bolus of D50, you can jack up the blood sugar, and then that in turn, and those diabetics are going to cause the pancreas to release more insulin. So you can kind of have like a roller coaster effect. With D10, the infusion, you kind of have less of that. So that's also another benefit with D10. So what if you have no IV access, right? So this is always the question, right? The patient's maybe combative, altered, or it's just a renal patient that has terrible access and you can't get IV access, right? So what's the thing? Especially you have 2 options, right? IO or IM glucagon. So IM glucagon, the main mechanism of action is it causes release of stored glycogen from the liver, and the liver will then produce glucose from those stored glycogen. The thing you got to think about is it only works if the patient has good glycogen stores already, okay? So any liver patient, a cirrhosis, alcoholics, anybody that's malnourished at baseline, they're not going to have a lot of glycogen stores. So this drug is not going to work. Okay, so that's just something you got to think about. Of course, it's going to be longer, right? You're not going to see that immediate rise as if you're giving sugar right through the IV. There are some formulations where you can give it intranasally as well, besides IM. The big thing is this is expensive, right? I don't know the exact price, but it's fairly expensive compared to other drugs. So what's your other option, right? IO. So you can give dextrose IO, you can give D50, you can give D10. in emergency circumstances. However, there are, of course, inherent risks to doing that, right? If you can avoid it at all possible, you don't want to drill somebody unless you need to. There can be complications down the road, especially in these diabetics that have poor wound healing at baseline. You can have poor wound healing of that site, okay? But it is an option, right? If you don't have glucagon, it is an option. Ultimately, it's going to be up to your agency with your medical director to decide what's the best route for those patients where you can't get IV access. You know, are you going to carry glucagon, or are you just going to drill people and give them dextrose? So you've given the patient glucose. Now the patient's not wanting to go to the hospital. They're learn-oriented ×4. What are your thoughts? What questions do you need to ask? What do you want to do? You want to just send them on their way? What y'all want to do? Okay, that's one option. Yeah. So you said put them in the ambulance before you give it to them. That way they're already there and they're like, yeah, I might as well go.
Decisions to care for themselves.
Yeah, so there are some good things to ask, and there's actually been a few protocols. There's no general census, but there have been a few good protocols for treat and release for hypoglycemic patients that you have treated and they've returned to baseline, okay? One of the good ones I found was NAEMSO was a clinical guideline they released in 2019. And this is what it showed, right? So basically they have to return to baseline. The glucose after you treat has to be greater than 80. They have to be on insulin or metformin, right? So why don't we ask that question, right? Because those other oral hypoglycemics that we talked about can cause rebound hypoglycemia. So if you're on those meds, you need to go to the ER, or at least advise the patient that, hey, you need to go to the ER. Patient has to return to normal mental status with no neurological signs, right? They have to be able to eat. They have to be able to tolerate PO, eat a meal. It's ideal if you can actually witness them eat a meal there, right? Have somebody able to stay with the patient. I think that's a great idea, and have no other symptoms, right? Like chest pain, I have dysuria and a UTI, and that's what caused me to be hypoglycemic to begin with. And I think it's reasonable if all these things are met, then you can say, hey, you know, we can always provide transport, but I think it's reasonable if you want to just follow up with a primary care doctor, you can do that. Okay. You know, there's a lot of different protocols out there, but at the end of the day, you just, whatever agency you're with, you need to just sit down and talk and create some kind of protocol. So in summary, have a low threshold to check a glucose on not only diabetics, but anybody with altered mental status, right? Especially pediatric kids with altered mental status. Ask about diabetic meds, because that's going to be important. Figure out why they're hypoglycemic if you can. I know that's not always easy to do in the field. Think about having a protocol in place, or an idea of what you're going to do if you don't have IV access. And then think about the treat and release protocols for after you treat hypoglycemia. All right, so let's kind of switch gears and talk about DKA. Okay, so hyperglycemia in itself is just defined as a glucose level over 200. Again, an elevated glucose level on its own is not necessarily an emergency, but hyperglycemia in the setting of DKA, of course, is an emergency. And again, these are sick patients, right? So the mortality of DKA, even if you do all the treatment right, is about 10%, okay? So that's all comers that come in with DKA, 1 out of 10 is not going to survive out of the hospital. They get submitted for DKA. Okay, so these are sick patients. I know we see this a lot, but these are critical patients. So what's the main issue with DKA, right? It's a lack of insulin. Right? It's not the blood sugar's too high. That's not the issue. It's a lack of insulin is the issue. Okay. So what happens is that you can think of insulin as the key to the cell that allows the glucose into the cell. Okay. Insulin is the key, right? So if there's no key, glucose can't get into the cell, and the cells start starving. Okay. They start starving. They try to find other means of energy. So they make ketones. That's where you get the ketosis from. They try to use the ketones as another source of energy. Ketones are very acidotic, so that's where you get your acidosis from. And all the badness just basically stems from the cells starving themselves because they don't have enough glucose within them. So what causes it, right? So sometimes it could be simple as, hey, I just didn't take my insulin. But usually it's more complicated than that. Usually they have an infection on top of it. They've had some kind of gastroenteritis and they're dehydrated. All these things can cause a diabetic to go into DKA just from the metabolic stressors themselves. So presentation, right? I'm sure y'all have all seen the classic DKA, which is somebody that's altered, they're breathing 40, 50 times a minute, they're taking in huge breaths, trying to blow all that acid off, right? But you can have non-specific symptoms. It can be not as straightforward as that always, especially if they're in mild to moderate DKA. You can just have abdominal pain, nausea, vomiting, feelings of weakness, very non-specific things. So you just have to keep that in mind in diabetics. So the treatment, right? Ultimately, they're going to need insulin, right? The issue is a lack of insulin. They're going to need insulin, right? That's ultimately what we're going to do to fix the problem. But what can we do on the way to the hospital, right? So a lot of these patients, because their sugar gets so high and they're acidotic, they'll diurese a lot of extra fluid off, so they'll be very dehydrated, okay? They'll be 2, 3, 4 liters down sometimes. So IV fluids is great in these patients. The caveat is in pediatric DKA, you're going to be very cautious with IV fluids. So there's this complication with DKA in kids where you can get cerebral edema because of the hyperosmolar shifts that happen. So you just have to be very cautious with IV fluids in these. So when these kids come into the ER at Children's, we'll not give them a bolus of insulin, we'll put them on an insulin drip, and we'll not give them necessarily a bolus of fluids, we'll put them on a kind of a fluid regimen over the next 4 to 6 hours to kind of slowly replete them to try to keep those osmolar shifts from happening as much. Again, these patients are very sick, right? They're severely dehydrated, they're tachycardic, they're breathing 40 times a minute, they're very acidotic. So if you think about normal pH, 7.35, 7.4, somewhere in there. A lot of these patients, when they're severe, they're close to 7. Sometimes they're below 7, they're 6.9, which is extremely acidotic. And of course, with that comes all the other issues. A lot of enzymes don't work in your body when you get that acidotic, and other things as well. Another thing is electrolyte arrangements are very common. Okay, so acid outside the cells will shift electrolytes around, so it'll actually shift potassium outside of the cells. So initially, these patients will be hyperkalemic. Okay, so you can see peak T waves on EKG just like you would a dialysis patient with hyperkalemia. Okay, so all these patients get fluids, they get put on a cardiac monitor, they get closely monitored all the way to the hospital. So again, in summary, they can have non-specific symptoms early on, mild to moderate. The base mechanism is a lack of insulin. The issue is not high glucose, the issue is no insulin. Again, severely dehydrated, you got to think about your electrolyte arrangements in these patients, and they're critical. Just briefly, I'm going to talk about this. I'm sure you've heard of it, HHS, hyperosmolar hyperglycemic state. So this is something else you can see with diabetics. This is not an issue of insulin. This is an issue of their sugar being so high over so long period of time that they have these complications, and most notably dehydration. Okay, again, these patients are going to be very dehydrated, 3, 4 liters down. You're really not going to be able to tell whether it's DKA or HHS in the pre-hospital setting before you get labs. There are some key giveaways. So if you see glucose in the range of like 600, 1,000, that can be more indicative of HHS versus DKA. And usually this happens over a longer period of time, and it's also more common in type 2 diabetics. So we see this a lot in elderly people. You come to their house, somebody hasn't seen them in 3 or 4 days, and they've been sitting there not eating, and their sugar's been 800 for the last 3 or 4 days, and it usually happens over a longer period of time than DKA. Again, the treatment is going to be similar for this. These are critical patients as well. These patients actually have a higher mortality rate than DKA patients. So they'll get admitted to the ICU, they'll be put on insulin drip, fluids, all that good stuff. So again, just talking about pediatric considerations, we talked about how we're going to be more cautious with IV fluids and DKA. You got to think about this in somebody that's not diagnosed with diabetes. If you come up on a kid that's altered and they have those signs of maybe DKA, that, hey, this could be first diagnosis. So you got to be thinking about that, even in those that are not diagnosed with diabetes. And you also got to remember, kids, they don't have as much of those glycogen stores in their liver. So any kind of acute illness, especially in the smaller kids, like under a year, they can get hypoglycemic from sepsis, really any infection, gastroenteritis. So that's something you got to be able to think about too and treat it accordingly. Again, when we treat hypoglycemia in the pediatric population, it's going to be a little different, right? We don't want to give them D50 because it is too irritating to the vasculature in peds. So usually we'll dilute to either D25 or D10. And again, you can look this up, if you're in the situation, but the dose is 5 mLs per kg of D10 or 2 mLs per kg of D25. Usually D10 is what I would go with in these patients. All right, we got a question.
Yep, got a couple for you. So the first one relates to this. How high should we look at blood glucose level to be the primary cause for altered mental status in both adults and peds? In other words, if it's, normal's 70 to 120, so is 150 enough to cause altered mental status?
So I would say, again, it's not necessarily the level of the glucose. It's going to be what is causing them to be altered, because just a high glucose level in itself, unless it's 6, 7, 8, 900, is not going to cause altered mental status. Yes, if they're in DKA, then that can cause them to be altered, but just a high glucose level in itself. So I wouldn't be worried on that number so much and say, oh, it's over this, and that's why they're altered. I'd be thinking about the other things. Is this kid in DKA?
Okay. Yep. So on the pediatric side of that, the mention was that we often see kids who are sick or injured have slightly elevated blood glucose levels.
Mm-hmm.
And anyway, so that's probably, if they have an altered mental status, it's probably not due to blood glucose under 300, you'd say, ish.
Yeah, so if they're over 300, I would be thinking about other things like is it DKA, or are they like septic or having some kind of infectious source that's causing them to be altered, and that's causing their blood sugar to be up.
Gotcha.
You have anything else to add, Ferg, on that?
I think classically we think glucose is greater than 250 to be DKA. But for the most part, you see it a little bit higher than DKA. Now, kids are different. They may have a lower glucose in the 250, 400 range because they do the diagnosed type 1s, right? I think for a number that makes me think glucose is causing their altered mental status because the glucose is so high, you can study changes. You look at it, glucose is like 800 or so. In most of your monitors, you're going to get high at 500, right? 400, so.
Yeah, and again, that's when you're going to be thinking about HHS.
Yeah.
When they get up in that range, 6, 7, 800.
The other thing I'd add is when you think about low glucoses, if you got somebody that's a type 2 diabetic and their normal fasting glucose is 300 or 400 because they have bad diabetes, if they get a glucose of 120, they may be a little bit confused, diaphoretic, and they may be relatively hypoglycemic as well, which is kind of weird. The good news is those folks don't die from hypoglycemia like a type 1 that's got a glucose of 30.
Very good, thanks. So the second question is probably a good segue to your other endocrine emergencies. So we had somebody ask, explain why someone with Addison's disease would be hypoglycemic.
Yes, we'll talk about that. That's coming up.
Okay.
To be continued.
To be continued.
Yeah.
Thank you.
I like that. I like that question though. That's good. All right. So not immediately. We'll talk about some thyroid stuff first. Any questions on diabetes? It's going to be, again, it's going to be 90% of what you see in the field. So any questions? Okay. All right. So we'll talk about thyroid. We'll talk about adrenal. Actually, adrenal is probably going to be a little bit more common than thyroid, even though thyroid kind of gets, I don't know, everybody gets excited when you talk about thyroid stuff. But so we'll talk about some thyroid basics and then the two extremes: hypothyroidism, hyperthyroidism, thyroid storm, and mixed edema coma. So again, thyroid, little gland, sits on your neck, kind of in front. It's actually kind of lower down than you think. It's almost close to kind of where your chest connects down here. A little bit lower actually than this picture shows. The main thyroid hormones are they're called T4 and T3, is two different ones that they produce. TSH, or thyroid stimulating hormone, is what's actually released from the pituitary gland that stimulates the thyroid to produce hormones, okay? So in somebody that's hyperthyroid, that has high thyroid hormones, they'll actually have a low TSH because of that mechanism. The brain's like, hey, we got too much hormone, we need to cut it out, and so your TSH will be low. So those will usually be kind of opposite. Just to note, you also see the parathyroid glands, which kind of sit basically on top of the thyroid. They are involved with calcium regulation. We're not going to talk about that really, but just for your information. So hypothyroidism, or insufficient thyroid hormone, is very common. Basically, you can think of everything goes down, right? So it slows cellular metabolism. There's many different causes. Iodine deficiency is common worldwide. It's not as common in the US because a lot of our table salt is supplemented with iodine. You can see chronic autoimmune disorders, infectious, and then you can see amiodarone will actually cause, it can cause both. It can cause a hypo or hyperthyroidism as well. The prevalence increases with age, so it's more common in elderly, and it's 10 times more common in female. So there's two different kinds, right? So there's primary hyperthyroidism, where the thyroid gland doesn't produce enough thyroid hormone. And then secondary is where you have a deficiency in the TSH. You have an issue with that pituitary gland not producing TSH, which stimulates the thyroid gland, right? So either two of those mechanisms could be having issues, and ultimately you don't have enough thyroid hormone. Symptoms very nonspecific for hypothyroidism. You see hair loss, depression, fatigue, weight gain. Cold intolerance is a big one that's always talked about in textbooks, you'll see. And then patients will usually be bradycardic at baseline. It almost looks like they're on beta blockers all the time. So why do we care, right? Hypothyroidism, not necessarily a medical emergency, right? But this is, okay, so this is mixed edema coma. So this is a person with undiagnosed hypothyroidism that has gone years with no diagnosis. So everything is down. That's kind of how I remember this. Everything is down, right? So the bradycardic, decreased mental status, hypotension, they don't ventilate as much. It's called mixed edema coma because you'll see this kind of woody, it's called woody looking edema in their lower extremities. That's kind of the giveaway for this. And then hypothermia is also key. So this is very common. 9 out of 10 patients with this diagnosis will be hypothermic. And again, that's because the cellular metabolism is all slowed down because there's not enough thyroid hormone. These patients can become hemodynamically unstable, and pressors won't work really that well until you get replacement thyroid hormone back up. Okay, so rare, right? You're not going to see this a lot, but it is something to think about in somebody with a history of hypothyroidism. Again, down here, you probably can't see it that well, but this is a picture of somebody with mixed edema coma. You can kind of see some lid lag come over, and you can see this woody looking edema, especially over the feet there. That's some nice looking toes. And then bradycardia on the right, if you can see that small image. So that's just all the things you'll see in mixed edema coma. Recognition is key. You got to be thinking about it. And again, a high mortality rate, even if you treat this, a third of patients will die with this diagnosis. Hyperthyroidism, so we'll swing the other way, right? You have too much thyroid hormone. Again, this causes from different conditions. Most often what we see in the United States is autoimmune disorder, Graves' disease. Sometimes you'll have nodules that are benign, but they'll produce extra hormones, so you can see it that way. And then what we really care about is thyroid storm, which you may or may not have heard about. That's a specific hyperthyroidism emergency, okay? So this is basically the end result of somebody with hyperthyroidism. You can have somebody with baseline hyperthyroidism, and then it'll get an infection or sepsis, and it will kick them into this, okay? Any kind of metabolic stressors, just like all the other endocrine emergencies, can cause this to get out of whack. So again, high mortality, so 60 to 80%. So this is even higher than mixed edema coma, 68% if untreated. They may complain of nonspecific symptoms, right? So they might just say, I just don't feel that well, maybe a little altered. But again, the big thing here is you're going to see a lot of things on exam. So they'll be agitated, you'll see some tremors, high blood pressure, tachycardia. A lot of times these patients will go into AFib even if they don't have diagnosed AFib. So you'll see AFib with RBR just because everything's ramped up from the thyroid hormones. You can see people, if they go in this for long enough, they can have high output heart failure, and that's just from the heart beating so fast for so long, it becomes weak, and you'll see a dilated cardiomyopathy from just beating so fast so long. Sweating, fever, all those things you can see. What we do in the hospital, there's different anti-thyroid medications we can give them. The biggest thing we like to do, first off, is to control kind of the end symptoms, all the tachycardia, tremors, things that's going to damage the heart. So we'll give them beta blockers up front to help with that tachycardia. And then there's kind of a different phases of treatments that we go through to kind of block the production of hormone, release of hormone, different things. And we do that in the ER. Okay, so now we'll move on to adrenal emergencies real quick. We'll talk about some basics, talk about adrenal insufficiency, which is not enough cortisol hormones that the adrenals produce, and then adrenal crisis, which is the kind of end result of that. So a lot of people get confused with adrenal crisis, thinking that it's the opposite of adrenal insufficiency, but it's not. It's just a lack of hormone that's kind of, you can think of it as equivalent to thyroid storm for hyperthyroidism. Okay, so adrenal crisis is just the end, most severe form of adrenal insufficiency. Sorry, I know that's complicated saying that. Hopefully that made sense. So adrenal glands, they sit just on top of the kidneys, right? Adrenal glands, they sit on top of the kidney. They produce a lot of different hormones. The ones we care about really are cortisol, which is a glucocorticoid, and then aldosterone, which is a mineralocorticoid. It also produces in the middle area, the outside area, it produces catecholamine. So that's all your epi, dopamine, norepinephrine, kind of those quick hormones that get you really revved up, right? Adrenaline. It also produces that as well. So cortisol is the biggie, right, that we think about, especially with Addison's disease. It has a ton of different responsibilities. It facilitates mainly your stress response in the body. So it can affect your water balance, your water secretion. It affects your electrolyte balance a lot. This is one of the key things we use to diagnose this is your sodium potassium will get really out of whack. Protein, metabolism, a lot of different things it functions on. And if you don't have enough of it, then the body doesn't like it. Aldosterone is the other big one. This deals more with the kidneys. It interacts with the kidneys with the renin angiotensin aldosterone system. That's our AAS, the main mechanism for which the kidneys control blood pressure. So aldosterone is the biggie there. And again, aldosterone is also going to affect your electrolytes as well. Speaking of the question earlier, cortisol is it's called a glucocorticoid. So it stimulates glucose release from the liver. So that's one of the reasons why if in Addison's disease, which Addison's disease is the same thing as adrenal insufficiency, it's just another name for it, is why you have people with hypoglycemia if they don't have the glucocorticoids or steroids, okay? So this is what we're talking about, Addison's disease, primary adrenal insufficiency. Basically, you have a lack of adrenal hormones, those glucocorticoids or mineral corticoids, aldosterone. Usual culprits, autoimmune disease, again, there's kind of a theme going here. Actually, worldwide, the biggest cause is tuberculosis infection. Will kind of knock out the adrenal glands, and you can have adrenal insufficiency. A lot of these patients, when they're diagnosed with this, they just have to be put on supplemental steroids, and they're taking it long term. Some of the symptoms you'll see associated with this: lethargy, weakness, low blood pressure, and those electrolyte abnormalities. So adrenal crisis is that end stage of this adrenal insufficiency. You don't have enough steroids, most specifically cortisol produced by the body. And what you end up getting is shock refractory to basically all your interventions, okay? This can result as like a new diagnosis in somebody that has really bad sepsis that can kind of take out the adrenal glands, or in somebody with a known history of Addison's disease, if they get some other metabolic stressor, it will send them into this. So the clinical feature of adrenal crisis is severe hypotension, and it's refractory to fluids and vasopressors, okay? Hypoglycemia is a big giveaway. If you see that, you got to be thinking about, oh, is this a steroid issue? Abdominal pain, nausea, confusion, sepsis. Even without fever, signs of fever, you can have sepsis with this. Again, the treatment is going to be replacing those steroids, okay? So when we come into the ER, we give them high-dose hydrocortisone, 100 milligrams. That's kind of our go-to because it's the quickest onset. This is actually in the EMS state protocols, right? I know a lot of people don't carry this, but it's in the protocols for you can give hydrocortisone, solumedrol, or Decadron if you want to carry it for this reason, okay? Especially in kids that are diagnosed with adrenal insufficiency. Sometimes they'll be actually given like a steroid pack or injector to go home with in case they start having these symptoms that can give themselves an injection, so you can see that as well. And then kind of the last thing before we wrap up here, we'll talk about Cushing's syndrome, right? So there's a lot of similar names here that are very confusing. So Cushing's syndrome, Cushing's disease, and then Cushing's triad, right? That always kind of throws a kind of a wrinkle in everything. So Cushing's syndrome is just a syndrome of too much cortisol, right? So that's the opposite of Addison's or adrenal insufficiency. It's too much cortisol, Okay, that's Cushing syndrome. For whatever reason it is, if you have too much cortisol, it's called Cushing syndrome. Now, Cushing's disease is a specific form of that, okay? And that's specifically caused by you have something wrong in your pituitary gland that doesn't produce enough ACTH. ACTH is the hormone that stimulates the adrenals to release cortisol, okay? You really don't, knowing the difference between those two is not as big, right? And then what is Cushing's triad, right? What is so this is nothing related to adrenal, endocrine, anything, right? It's just a long time ago, the same guy, you know, thought he was smart and wanted to name all this stuff after himself. So again, Cushing's triad, right? So that's in brain injuries, increased intracranial pressure. That's where you see, you know, the bradycardia, hypertension, irregular breathing with somebody with greatly increased ICP, right? We call that Cushing's triad or Cushing's reflex, okay? And that doesn't have anything to do with what we're talking about here. That's just kind of just thrown into to confuse people. So just in summary, as far as kind of hyperadrenalism and talking about Addison's or insufficiency, it's actually more common than you think. And actually because, as we'll talk about in one of the cases, a lot of people are on chronic steroids. So lupus, any kind of autoimmune disease, if you're diagnosed with that, they're going to put you on like a baseline steroid. And your body's going to get used to you taking in that steroid over time. So if for some reason you start taking that, you run out of your medication, or you have some kind of insult to your body that causes your body to be stressed, we can see adrenal crisis actually more common than you think. All right, so let's go back to our cases. The police finally wrangle your 23-year-old male. You check his glucose. It's in the toilet. After successful IV access, you give him some glucose. He gets better. He calms down and starts asking why everybody's staring at him, right? And then goes to the hospital. Case 2, this is kind of trickier. So remember, this is your 53-year-old guy, tachycardic. So you get IV access on him. You're thinking maybe sepsis. You start some fluids. You get him to UAB. UAB, somebody miraculously checks a TSH, and it's found to be undetectable, right? So that's really low. So what does that mean? Your TSH is really low. So that means you have too much thyroid hormone, right? Your brain is trying to suppress that. That's why your TSH is low. So your thyroid hormones are very, very high. So what was this guy in? If you remember, it's tachycardic, sweaty, agitated. Yeah, hyperthyroidism, Thyroid Storm. Okay. And then the kind of hint here was he recently started on sorry, that shouldn't be anti-thyroid. Or sorry, yeah, he started on anti-thyroid in the ER. Remember, this is a guy that was just started on amio a few weeks ago for heart issues. So amio is a known cause of hypo or hyperthyroidism. So we'll see people come in with thyroiditis from amiodarone, and they can be in Thyroid Storm from this. So that's kind of the weird. And then this is the last case. You get IV access on your 73-year-old female. You give some fluid, normal saline. Nothing really happens with their blood pressure. It's still 70/40. You're like, oh, okay. You go to the nearest ER. In the ER, they're like, oh, maybe sepsis. So they start a norepi drip. Titrate it up, titrate, nothing happens, right? ER physician eventually realizes, hey, this could be adrenal crisis, and gives steroids. And then over the next 2 to 3 hours, the hemodynamics improve. And I put this in there because this is usually how it works. It's kind of an underthought of, hey, we've tried all this stuff and it's not working. So then we'll add on steroids at the end and they get better. So that's it. Questions, comments? Exciting, not exciting?
Protocol is the patient has to have their own accompanying medication.
Is that for the state protocol? Yeah, I was looking at it last night. I couldn't remember if that was, and I think that was specifically written for more Peds cases too. So that would be, so the question, or what he was saying was the state protocol for giving steroids for somebody with adrenal insufficiency is they have to have their own accompanying.
It's got the doses in there. It says, calls it out.
Yeah. Anybody carry steroids? Cool. Any questions on the interweb?
No, sir, not so far. We got a little bit of chatter through text about the improbability that we would ever notice the adrenal or thyroid brain issues.
Yeah, that's great. You're right. I agree with that. I think it's still good to know, right? Because the more you know, the more you'll be thinking about stuff. But yeah, they can be difficult to diagnose. Even in the ER, these can be difficult to diagnose. So yes, I understand it's rare, and it's unlikely that these would be caught in the pre-hospital, but I think it's still good to know and to be aware of it.
I agree.
Yeah, the hyperthyroid stuff, you just pick it up and we move everything out.
Yeah.
So it's usually, I thought somebody was septic or had meningitis or something else going on, I work them up. And then like an hour and a half later, I get a lab test, oh, now I know what's the problem.
And the same thing with adrenal insufficiency too. Usually we've done everything and nothing's working, so they're like, oh, maybe it's adrenal insufficiency.
All right, great. Hey, thank you for the great lecture, Dr. Payne and Dr. Ferguson, as always. Really good stuff. Thank you all who attended in person and online. Remember to please fill out an attendance form. You'll get an automated certificate through email. If you can get the link in the chat box, that's good. If you're here in person, you can scan the QR code. You can also send an email to alabamaemschallenge@gmail.com. Doesn't matter what the email says, but please be nice. And you'll get an automated return with a link to the attendance form, and you can get your certificate that way. And that's all we've got for our December edition. If you're close by Southside, come join us at Brim's. We got lunch coming, followed by a skills lab. We got Med Cognition here, who's going to do a great demonstration on their virtual reality EMS training system. We're going to have scenarios with the doc, pig tracheas for surgical airway, some advanced airway training, or difficult airway training, I should say, is more accurate. And so if you're around the area, please come by and join us. We'd love to have you. If not, we'll see you next time.
Back the third week of January, because of the holidays, we'll start the third week of January.
Yep, that's right. So next class will be third week in January. We'll get started back on our regular schedule for 2022. Hopefully we'll have a list posted on the Alabama Fire College web page of our schedule for at least several months out in advance for 2022 coming up. And thanks to Alabama Fire College for making all this possible by their sponsorship. That's all I got. Doc, you got anything else? Nope. See everybody next time. Thanks.